Okay, so here we go, and welcome everybody here in the Sim Week session on the theme of excellence, and we'll go for a half an hour together with our guest today, Debra, that I will present you in a few minutes. Here today we are here to talk about excellence with SPs, and you will hear the talk of Debra on that topic, and you'll have the chance to ask some question. I have the honor to facilitate this moment of simulation community with you, and just a few words on who I am, because this guy, nobody can know this guy from France. My name is Fouad Marhar. I'm working in anesthesiology and intensive care in the southwest of France, around Toulouse. And I'm also involved in simulation. Like I began in 2011 simulation when I was resident, and I'm most of the time implicated on organization of the session of simulation. I'm more on the field of simulation, and I also run some train the trainer programs with USIM, and some SP programs, and I help some people in France to deliver SP program. And I have some research activity on stress, and I'm in a network called COVID Stress that you can check on, that is studying stress that was happened in the workers during the COVID. So that's who I am. And I was invited by Amy Copperwaite in this great part of Sim Week, so I'm very pleased to be there. But you do not choose this webinar for me. You choose this webinar because we have a guest today called Debra Nestel. Hi, Debra.
Hi, Fouad. It's really wonderful to be here, and I love that you're in Paris and I'm in Melbourne. And sorry, you're in Toulouse and I'm in Melbourne. I've just been in Paris. Back to you.
Just a few words on your bio that maybe not everybody knows you perfectly, that as we. So you are a professor of simulation education in healthcare in Monash University, which is in Melbourne. You are also professor of surgical education in the Department of Surgery, which is also in University of Melbourne in Australia. You are editor-chief in International Journal of Healthcare Simulation, which is a brand new journal, and the program lead of the graduate program in simulation, in clinical simulation, and graduate program in surgical education, both in Melbourne, University of Melbourne and Monash University. So you lead a faculty development program for simulation practitioners, the NHAT SIM, and you receive awards, a lot of awards, but you received the award of Member of the Order of Australia for your services in healthcare simulation, and you also was recognized as a presidential citation from the FSSH here in the US. So, and of course, you have this very prolific research activity. So you published more than 200 peer reviewing papers in health professional education, and you also edited a lot of books, and 4 main books on this major topic. So that's actually very, very impressive to have you with us today, because I think personally that we can have the chance to talk really about SP, your SP experience that you gain in different places. Maybe it's the time for us to go with the presentation. So here we go with a 13-minute presentation, and it will be great to put out all the microphone during the presentation. And if you have any question, feel free to put the question on the chat. I will try to get them and ask them to our two guests. So I will put off my mic, and here we go with the presentation. Okay, great. Curtis, you can put on the video.
Debra does not look muted.
Yes. Curtis, we don't have the sound.
Okay.
Thanks for the opportunity to talk with you today. I feel very honoured to speak on this topic and to actually anyone giving up their time to listen. So thank you very much. My name is Debra Nestel. I work across two universities, the University of Melbourne and Monash. Both are located in Melbourne, Australia. And I've worked with SPs. I'm just going to use the phrase SPs from now on, but referring to simulated participants. I've worked with SPs in Hong Kong. That's where I did my PhD in SP methodology, graduating in 1997. And then I worked in London at Imperial College, and now I've been back in Australia for over a decade. And all of this has actually been over about 35 years. So I witnessed many changes in that time in healthcare simulation generally, and specifically in SP methodology. And I should also declare that my experience covers educational practice, especially simulation design, faculty development, SP development, and I have also researched in this area too. I want to draw attention to an alternative title, and I did propose the first one, so that's my responsibility. I'd shift that first word to aspiring, to aspiring rather than attaining. And it's a tough call to attain excellence every time. I think we need to be kind to ourselves and our SPs and others we work with, that not attaining excellence every time is actually okay as long as we are working towards it. I also want to draw your attention to this word with, and if that is the only thing you take from the session, then I'm going to take that as a win. There's a tendency to objectify SPs in our language, set with phrases such as, we use SPs, it's commonly heard, and I'd really encourage you to think about replacing that phrase, using SPs, to working with SPs. Well, it's a nuanced difference. It conveys a compelling story of power, distance, and respect, and SP agency. So, important to ask, having read the title, what does excellence look like? And I invite you to take a moment to think about that in your own practice. Because excellence is likely to look different depending on whose perspective or lens you're making that judgment from or through. And I think this is so often overlooked. It's important to remember there are multiple stakeholders in SP methodology: patients, SPs, clinicians, learners, SP educators, health and social care service providers, and the broader community. From an SP educator perspective, Lewis and colleagues sought to identify best practices in SP methodology, and this is an important document, and I urge you to look at it, and I applaud the authors, and I declare that I was involved in some stages of their development very early on. However, it is a limited view because it is written by SP educators, largely for SP educators. The article is exclusive of the perspectives of patients, of SPs themselves, of learners, and so on. So it's an important story, but a partial one. The standards are very much positioned in the genre of writing, of doing two SPs, again, risking objectification rather than doing with. And why is this important? It's important because without real patient involvement, much SP-based work is a mirror for the teacher's preconceptions rather than as an authentic reflection of a patient encounter. This is sometimes referred to as the clinical gaze. And I'm not suggesting that this is an intentional manipulative ploy of teachers or faculty. I'm simply highlighting the challenge of for those immersed in teaching and the delivery of healthcare to see through the eyes of someone who is not, as someone who is the recipient of care. A prominent patient advocate, the late Dr. Rosamund Snow, reinforces this view with her statement that the patient voice continues to be filtered through clinicians' perspectives. She goes on. When no real patients were involved, two major assumptions are made. Firstly, that actors and faculty members who brief them can really simulate patients, that they know how real patients would respond in a given scenario. Secondly, that many outcomes set by healthcare personnel are the most appropriate for the situation, that real patients would want students to learn those things. The complexity of this challenge of seeing through patients' eyes is evident in the many published accounts of doctors' experiences as patients and how utterly different being on the receiving end of care is to that of the professional provider. And it's not just in medicine, there are examples across the health professions. And for many years, even a couple of decades, professional organizations and licensing bodies increasingly promote active roles for patients and the public. And we see this in broader health services research. Patient involvement in shaping what is research has absolutely gained traction. However, standards of practice for simulation, of which there are many, are largely exclusive of direct patients' voices. While the many standards documents of INACSL offer really thoughtful guidance, but there's almost no mention of patients or even SPs as partners in the simulation. So following this thread and getting back to the question of what excellence looks like, I think excellence is when we're getting closer to co-construction of content, especially with patients' perspectives, because I hold very strongly the view that SPs, when the P is for patient, must have real patient involvement at some point, and not every time. That's probably impractical, but sometimes. The idea of co-construction has long been promoted, and I refer to the recent work of Dr. Linda Nikinon and her colleagues, and the title says it all. Nothing about me without me. This is a scoping review exploring patients' contributions to SP methodology. The authors write that simulation-based education must seek to move beyond the paternalistic assumption that clinicians know best. They continue with authentic illness experiences help create meaningful person-centered simulation education. And they conclude, patients' voices profoundly enrich the educational contributions made by SPs. I'm staying with the scoping review a little longer because to me this is what excellence looks like. It is where patients' perspectives are directly informing our practices. And this is an excerpt from their paper, which I'll quickly read. Traditionally, SP's rules have been informed by the clinical gaze. Nestel et al. Urge us to think seriously and artistically of ways to include the person with the experience. An SP can be any person who is willing to take on the responsibility to portray an illness experience, irrespective of having had that illness experience. Central to their role is the need to represent authentic clinical encounters to benefit health professional development and training. It's recognized that such verisimilitude can create anxiety among learners. But the advantage of realism in simulation is to help learners develop confidence, which is transferable to actual life contexts. There are many other influences on excellence in SP methodology, which theories are also prominent, but often underrepresented. And I'm continuing with underrepresentation. There's no scope in this talk to explore them here, but it's an important area of practice to consider. And I encourage you to seek out the work of Dr. Karen Salter, who compiles an annual selective bibliography of SP research. I want to move to closing now, and again, finish with some provocation. Here, I argue that making reference to SPs as standardized patients just sends all the wrong messages to how we see and value patients. I prefer to talk about simulated patients who can standardize their portrayal, for example, in an OSCE. SPs are trained to portray their role within a certain bandwidth, preferably informed by real and simulated experiences too. But in plain speak, as an adjective for live humans, the phrase standardized is just unpalatable. Referring to patients as standardized is in tension with their individuality of notions of patient-centeredness. That's at the heart of safe clinical practice. The phrase standardized reinforces that notion of objectification of patients as cases, stripping them of their personal human qualities. Patients can then become known by their condition rather than their personal identity. It reinforces that notion of the fractured neck of femur in bed 9. So, while the phrase is commonly used, I think we need to critically reflect on the messages that we are sending by retaining it. When I shared this phrase with a patient advocate, they reacted strongly with, "You must be kidding, that's so dehumanizing." I offer 5 articles to challenge your SP methodology in your pursuit of excellence. And these are, here we go, that's the letter they're called what. Here are the readings. From Lewis, the standards of best practice guidance, they're really valuable and they're a limited view. Then you can see that I cited 2 pieces of work of mine, one that's actually quite old now, thinking about authentic patient perspectives, a more recent essay that I wrote with colleagues from around the world, where we looked at values and value in SP methodology. There's the article or the book chapter from Mosman Snow on how real patients can participate in simulations. And there's the scoping review from Linda Nikinon on Nothing About Me Without Me, a scoping review. So in summary, I started by emphasizing the importance of working with SPs rather than using them. I made reference to the many standards documents in healthcare simulated and highlighted that while they're valuable, they have a limited perspective. In many, patients are not even mentioned, or when they are, it's not in the context of partners in education. I recommend the scoping review by Nikki Norn that shares several approaches to working with patients in SP methodology. And then I invited you to critically reflect on the phrase standardized patient as being in tension with patient-centeredness, preferring the umbrella term of simulated patient when the P is for patient. So thank you. Please contact me if you need access to the references, and I wish you a very happy healthcare simulation week. Thank you very much.
Thank you, Debra, for this interesting talk. And we have the chance now to spend quite a lot of 10 minutes to have some questions. So feel free to ask. We already have questions in the chat that you already answered, but maybe I can share the question with everybody. So the first question from Sawyer was, is there any resources for developing SP training curriculum? Do you have any answer, Debra, for this question?
Yeah, look, it's a terrific question, and there are a number of publicly available resources. I work with a group called the Simulated Patient Network, and I'll pop that web address into the chat shortly. But in the last year, we've actually moved a number of our courses over to healthy simulation, and those courses they're designed to prepare anyone who's going to be working with SPs to offer kind of fundamental principles about their practice. The work is done together with Kathy Smith, who works in Canada, and one of my colleagues in Australia, Jennifer Harlem. So the three of us have combined forces to create those resources. So you may find them valuable.
Thank you for your answer. And actually, everyone is thanking you for this presentation and this insight on the semantic of the simulation. That's what I feel on this topic. Maybe I can take 1 minute to ask you this question I had after your topic is, can we really use real patient for training? I mean, is there any special things that we have in the process and simulation with this kind of SP? And where is it in the process that we have to change things or to be flexible?
Yeah, look, it's a really good question, and Fouad, and I also need to be clear, it's not an easy process engaging real patients in our simulation activities. Now, I'm also not suggesting that we need to do it every time. One of the reasons we don't have real patients in our simulation activities is that it's strenuous work, it's rigorous work, and real patients may not be in a position to support our learning. So I have on a number of occasions, and I'll give you a very specific response, or rather a specific example. I was working with final year medical students, and we were required to provide quite complex patient histories for the SPs with whom we were working. Most of our educational practice tended to focus on one system, one patient system, but these students were going to be going out into real clinical practice the following year. So we wanted to support them with a more complex patient base. So rather than us construct these, the patient characters and the patient histories, we actually invited patients who attended a particular clinic to see if they would work with us to share their history about creating a singular character for the portrayal by an SP. And this involved bringing the real patient who was well into meet firstly with the SP faculty, but then directly with the SP. And one of the power of this meeting was that it actually reminded all of us of the responsibility we have in representing patients' views. By never having patients present, I think it's easy for us to forget the weight of that responsibility. And I could go on and share exactly how that played out. It was in the development stage, so it wasn't really co-construction with the SP. It was more a real patient sharing their experience of their illness and a little bit of who their character was as well.
Great, thank you. We have two more questions, and I will ask you to give to give us like a 1-minute answer for each question, if it's
Sure.
possible. So do we have a special ethical consideration in choosing the SPs? And the question is more on vulnerable patients like pregnant women or children. Can we have more?
Absolutely. Look, I'm just going to share with you an observation that I think that SP methodology has become so nuanced that we now see guidelines for SPs who are children, SPs who are adolescents. There are guidelines for SPs who are older adults. And to me, this is an indication of the maturation of where this practice is now at. I think the care and well-being of our SPs is absolutely at the forefront of what we do. While an SP may be able to portray a role one day, they may not psychologically feel safe or comfortable to play it the next day. So we have to have this constant checking in process that they're okay to play the role that they will be involved in. What I'd like to do is to share links to a couple of the resources that again are open access materials that absolutely address these issues. Sorry, that's 1 minute.
Okay, great, thank you. And maybe we have the chance to get one last question, which is in the topic of excellence. So the question is excellence a myth or attainable? So you deal with that in the title. And the person asks us 3 points to focus upon this quest and 3 markers that we are on the right path. So my perspective is always from whose perspective is excellence being judged? Is it from the SP's perspective? Is it from a real patient's perspective? Is it from your SP educator perspective, your clinician perspective? We often don't think to bring these things into alignment. And I guess that's probably a pretty good point on which to end. Okay, thank you for this last answer. So if I tell it right, that's the time for us to wrap up this session. And that was an amazing pleasure to be with you today, Debra, and all the guests in this webinar. So a real thank you for your participation. And Curtis give you all the information if you want to go to continue the journey in excellence in simulation during this simulation week. So really thank you for your presentation, Debra, and for your answers, and thank you for everybody to be here today.
And thanks, Fouad. If anyone wanted to email me, I can forward links to some of the resources that I shared. And I've placed my email in the chat space. Thanks very much, Fouad.
Thank you.
Thanks, everyone.